Question 1. Respiratory care sciences. Pulmonary ventilation and gas exchange. Which of the following factors does not directly affect the efficiency of pulmonary gas exchange in the alveoli? A. The partial pressure gradient of gases. B. The surface area of the alveolar membrane. C. The thickness of the alveolar capillary membrane. D. The presence of pulmonary edema. Answer: D. The presence of pulmonary edema. Explanation: the efficiency of pulmonary gas exchange is primarily determined by the partial pressure gradient of gases. A. The surface area available for diffusion. B. And the thickness of the alveolar capillary membrane. C. Pulmonary edema. D. While it affects overall lung function, does not directly affect the intrinsic mechanisms of gas exchange as the other options do. Pulmonary edema increases the alveolar capillary membrane, thus impairing gas exchange, but its primary impact is more on ventilation. Question 2. Patient assessment. Arterial blood gases, ABAG analysis. A patient presents with ETVISH 7.30 ECO of 50 fathom/G and a bicarbonate level of 25 meckel. Which of the following conditions is most likely causing these ABAB results? A. Respiratory acidosis with compensation. B. Metabolic acidosis with respiratory compensation. C. Respiratory alkalosis. D. Metabolic alkalosis. Answer: A. Respiratory acidosis with compensation. Explanation: the pH of 7.30 indicates acidemia. A CO of 50 fathom/G is elevated, suggesting hyperventilation or respiratory acidosis. The bicarbonate level of 25 meckel, although normal, is consistent with partial compensation by the kidneys. Respiratory acidosis typically results in a compensatory increase in bicarbonate over time, but in case there is only partial compensation, indicating the acute nature of the problem. Thus, the most likely cause of the ABAP results is respiratory acidosis with compensation. Question 3. Airway management. Scenario-based. Mr. Thompson is a 65-year-old patient who presents with severe respiratory distress. His oxygen saturation is 88% on a non-rebreather mask, and he is unable to speak full sentences. His respiratory rate is 30 breaths per minute, and he is using accessory muscles to breathe. What is the most appropriate next step in management for this patient? A. Increase the flow of oxygen on the non-rebreather mask. B. Start bi-level positive airway pressure BiPAP therapy. C. Intubate the patient immediately. D. Administer a bronchodilator via nebulizer. Answer: B. Start bi-level positive airway pressure BiPAP therapy. Explanation: in this scenario, Mr. Thompson presents with signs of acute respiratory distress, including the use of accessory muscles, inability to speak in full sentences, and low oxygen saturation. BiPAP bi-level positive airway pressure is the most appropriate intervention because it can help improve oxygenation and ventilation in patients with severe respiratory distress, particularly those with conditions like COPD exacerbations or acute pulmonary edema. Increasing the oxygen flow on the non-rebreather mask may not be sufficient. Intubation C is invasive and typically reserved for cases where non-invasive measures fail or if the patient is unable to maintain airway patency. Administering a bronchodilator D may provide some benefit if bronchospasm is contributing, but it does not address the underlying issue, respiratory distress, adequately. Question 4. Mechanical ventilation. Ventilator settings and modes. A 72-year-old patient with acute respiratory failure due to chronic obstructive pulmonary disease (COPD) is placed on a mechanical ventilator. The doctor orders the use of SIMV mode with a tidal volume of 500 ml, a respiratory rate of 12 breaths per minute, and HPEEP of 5 centimeters HUT. What is the primary goal of setting the ventilator mode in this patient? A. To provide full ventilatory support and allow complete rest of the respiratory muscles. B. To allow the patient to breathe spontaneously between ventilator breaths while ensuring a minimum set rate. C. To increase airway pressure to assist in oxygenation and ventilation. D. To improve lung compliance by adjusting the tidal volume. Answer: B. To allow the patient to breathe spontaneously between ventilator breaths while ensuring a minimum set rate. Explanation: SIMV, synchronized intermittent mandatory ventilation mode, is designed to allow the patient to breathe spontaneously between ventilator breaths while maintaining a minimum set rate of ventilation. This allows for a balance between providing mechanical ventilation support and allowing the patient to exercise their respiratory muscles. This is especially important in patients like those with COP, where spontaneous breathing can improve comfort and reduce the risk of muscle atrophy. Option A refers to assist control mode, not SIMV. Option C pertains to pressure support or pressure control modes, and option D addresses tidal volume adjustments, which are not the primary focus of SIMV mode. Question 5. Oxygen therapy and aerosol therapy. Oxygen delivery systems. A patient with acute asthma exacerbation requires supplemental oxygen. Which of the following oxygen delivery devices would be most appropriate for this patient in the emergency department? A. Simple face mask. B. Venturi mask. C. Non-rebreather mask. D. Nasal cannula. Answer: C. Non-rebreather mask. Explanation: in an emergency setting like an asthma exacerbation, a non-rebreather max NRB is the most appropriate choice as it provides high-flow oxygen up to 90,100% and is ideal for patients in severe respiratory distress who require immediate and high oxygen delivery. The simple face mask delivers a lower concentration of oxygen and is not typically sufficient. Acute exacerbations. The Venturi mask B is used for precise control of oxygen concentration, but is less useful in acute emergencies where high oxygen flow is needed. A nasal cannula D is less effective in such situations, especially when the patient's respiratory needs are elevated. Question 6. Patient assessment. Chest X-ray interpretation. A 45-year-old male with a history of smoking presents with cough, dyspnea, and weight loss. A chest X-ray shows hyperinflation, flattened diaphragms, and a decreased vascular marking at the lung bases. Which condition is most likely present based on these X-ray findings? A. Pulmonary edema. B. Chronic obstructive pulmonary disease, COP. C. Pulmonary fibrosis. D. Pleural effusion. Answer: B. Chronic obstructive pulmonary disease, COPT. Explanation: the chest X-ray findings of hyperinflation, flattened diaphragms, and decreased vascular markings are classic signs of COPT, typically seen in emphysema, which causes airway destruction and lung hyperinflation. Pulmonary edema would show vascular congestion and possible alveolar opacities. Pulmonary fibrosis C would show diffuse interstitial changes, and pleural D would present with blunting of the costophrenic angles, none of which fit the description in this case. Question 7. Respiratory therapy techniques. Inhalation therapy. A patient with chronic bronchitis is being treated with aerosol therapy. Which of the following statements about bronchodilator therapy is most accurate? A. Aerosolized bronchodilators should only be administered when the patient is in acute respiratory distress. B. Aerosol therapy is not effective for relieving symptoms of chronic bronchitis. C. The use of nebulizers is preferred over metered-dose inhalers (MDIS) for bronchodilator delivery in most patients. D. Bronchodilators act by relaxing smooth muscles in the airways, improving airflow and reducing wheezing. Answer: D. Bronchodilators act by relaxing smooth muscles in the airways, improving airflow and reducing wheezing. Explanation: bronchodilators work by relaxing the smooth muscle of the airways, which helps to relieve bronchospasm, improve airflow, and reduce symptoms such as wheezing and shortness of breath. This is the mechanism of action of both inhaled and aerosolized bronchodilators. Aerosolized bronchodilators should not be used only during acute distress. They are an ongoing therapy for chronic conditions like chronic bronchitis. Nebulizers are often used in acute settings for patients who cannot coordinate MDI use C, but MDIs are generally more effective for most patients when used correctly. Option B is incorrect as aerosol therapy is effective in managing symptoms of chronic bronchitis. Question 8. Neonatal and pediatric respiratory care. Neonatal resuscitation and care. A preterm neonate is born at 30 weeks gestation with respiratory distress syndrome, RDS. What is the initial treatment of choice for this neonate? A. Surfactant replacement therapy followed by mechanical ventilation. B. Immediate intubation and mechanical ventilation without surfactant. C. Oxygen therapy via nasal cannula. D. CPAP continuous positive airway pressure therapy with high oxygen concentration. Answer: A. Surfactant replacement therapy followed by mechanical ventilation. Explanation: the initial treatment for neonates with respiratory distress syndrome (RDS) includes surfactant replacement therapy, which helps reduce surface tension in the alveoli and improves lung compliance. This therapy is followed by mechanical ventilation if necessary. Surfactant therapy is essential in premature infants who lack adequate surfactant. Immediate intubation may not be necessary unless the infant is not maintaining oxygenation or ventilation. Oxygen therapy, C, may be used, but surfactant replacement and proper ventilatory support are more important in RDS. EPAP D is useful, but surfactant therapy is the primary treatment for RDS in preterm neonates. Question 9. Mechanical ventilation. Ventilator management and monitoring. A ventilator is alarming with the message, high pressure. What is the most likely cause of this alarm? A. An obstruction in the endotracheal tube or ventilator circuit. B. Drop in tidal volume below the set parameters. C. The patient's PCO is elevated. D. Malfunction in the ventilator's oxygen supply. Answer A. An obstruction in the endotracheal tube or ventilator circuit. Explanation. A high-pressure ventilator alarm typically indicates that there is an obstruction in the ventilator circuit or endotracheal tube. This could be caused by mucus plugs, kinked tubing, or patient biting on the tube. Elevated ECOC or decrease in tidal volume B would not directly cause high-pressure alarm. Malfunction in the ventilator's oxygen supply D would more likely cause an oxygenation problem, not high-pressure alarm. Question 10. Respiratory pathophysiology. Obstructive lung diseases. A patient with chronic obstructive pulmonary disease COPD presents with a productive cough, increased shortness of breath, and wheezing. What is the underlying mechanism contributing to the airflow limitation in this patient? A. Thickening of the alveolar capillary membrane. B. Bronchoconstriction and mucus hypersecretion. C. Decreased lung compliance and stiffening of the lungs. D. Loss of surfactant leading to alveolar collapse. Answer. B. Bronchoconstriction and mucus hypersecretion. Explanation. In COPD, the primary mechanisms contributing to airflow limitation are bronchoconstriction and mucus hypersecretion. These lead to narrowing of the airways, obstruction of airflow, and difficulty in exhalation. Option A refers to restrictive lung diseases, not obstructive diseases like COPD. Decreased lung compliance, C, and loss of surfactant, D, are associated with restrictive diseases like pulmonary fibrosis or ARDS, not COPD. Question 11. Pulmonary function testing. Interpretation of spirometry. A 55-year-old smoker presents with a chronic cough and shortness of breath. Spirometry shows a decreased forced expiratory volume in 1 second FEV and a decreased forced vital capacity FEC with a normal FEV ratio. What is the most likely diagnosis? A. Restrictive lung disease. B. Obstructive lung disease. C. Mixed obstructive and restrictive lung disease. D. Normal pulmonary function. Answer A. Restrictive lung disease. Explanation. A decreased FEV and FEC with a normal FEV ratio is suggestive of restrictive lung disease where both FEV and FEC are reduced proportionally. In obstructive lung disease, the FEV would be significantly reduced compared to FEC, resulting in a decreased FEV ratio. Mixed obstructive and restrictive lung disease would show both decreased FEV and FEC with an abnormal FEV ratio. Normal FEV ratio rules out obstructive disease. Question 12. Non-invasive ventilation. CPAP versus BiPAP. A 60-year-old patient with acute exacerbation of congestive heart failure CHF presents with dyspnea and significant hypoxemia. The physician orders continuous positive airway pressure CPAP therapy. What is the primary purpose of CPAP in this patient? A. To provide ventilatory support by adjusting the respiratory rate. B. To decrease the work of breathing by delivering a set inspiratory pressure. C. To improve oxygenation by preventing airway collapse during expiration. D. To increase expiratory pressure, reducing the risk of atelectasis. Answer. C. To improve oxygenation by preventing airway collapse during expiration. Explanation. CPAP delivers continuous positive pressure throughout the respiratory cycle, helping to keep the airways open during both inspiration and expiration. This prevents airway collapse, which is especially beneficial in conditions like CHF, where fluid accumulation can cause alveolar collapse. Option A refers to ventilatory support provided by modes like BiPAP, while option B is more related to BiPAP's inspiratory pressure support. Option D describes the benefits of BiPAP in managing conditions like COPD. Question 13. Respiratory therapy techniques. Incentive spirometry. A postoperative patient who recently underwent abdominal surgery is instructed to use an incentive spirometer to prevent atelectasis. Which of the following is the primary benefit of using an incentive spirometer in this patient? A. It increases airway resistance to prevent bronchoconstriction. B. It helps expand the alveoli, improving ventilation and oxygenation. C. It decreases mucus production, reducing the risk of infection. D. It provides positive pressure to support the inspiratory effort. Answer: B. It helps expand the alveoli, improving ventilation and oxygenation. Explanation: incentive spirometry encourages deep breathing by creating a visual incentive for the patient to inhale slowly and deeply, which helps expand the alveoli and prevent atelectoses. This improves ventilation and oxygenation. Option A is incorrect because incentive spirometry reduces airway resistance rather than increasing it. Option C is not a direct function of incentive spirometry, though deep breathing can help in mobilizing secretions. Option D describes the function of devices like CPAP or BiPAP, not incentive spirometry. Question 14, respiratory pharmacology. Corticosteroid inhalers. A 50-year-old patient with asthma is prescribed a corticosteroid inhaler. What is the most important aspect of patient education regarding the use of this medication? A. The medication should only be used when the patient is experiencing an asthma attack. B. The patient should rinse their mouth after using the inhaler to prevent oral thrush. C. The medication should be used to relieve acute bronchospasm immediately. D. The patient should avoid using the inhaler during physical exercise to prevent side effects. Answer: B. The patient should rinse their mouth after using the inhaler to prevent oral thrush. Explanation: corticosteroid inhalers can cause oral thrush fungal infection in the mouth. As a side effect, rinsing the mouth after inhaler use helps to reduce this risk. Option A is incorrect because corticosteroids are used as a long-term control medication, not for acute relief. Option C refers to bronchodilators, not corticosteroids. Option D is incorrect because corticosteroid inhalers should be used as prescribed, regardless of physical activity, to manage asthma symptoms. Question 15, acute respiratory failure. Causes and management. A 60-year-old patient with a history of COP presents with increasing dyspnea, confusion, and a POW 5-MHg and POCO 6-MHg. What is the most appropriate next step in the management of this patient? A. Administer high-flow oxygen via non-rebreather mask. B. Initiate non-invasive positive pressure ventilation (BiPAP). C. Intubate and mechanically ventilate the patient immediately. D. Administer sedatives to reduce respiratory distress. Answer: B. Initiate non-invasive positive pressure ventilation (BiPAP). Explanation: this patient is showing signs of acute respiratory failure with hypoxemia and hypercapnia commonly seen in exacerbations of COPD. BiPAP, bi-level positive airway pressure, is the preferred non-invasive ventilation technique to support the patient's breathing by providing positive pressure during both inspiration and expiration. It helps to improve gas exchange, the work of breathing, and prevent the need for intubation. Option A provides high oxygen flow but does not address the elevated CO levels effectively. Option C would be considered if the patient deteriorates or does not respond to non-invasive ventilation. Option D would worsen the patient's respiratory status and should be avoided. Question 16. Asthma management. Medication use. A 22-year-old patient with asthma presents to the clinic for a follow-up appointment. They report using their albuterol inhaler several times per week for symptoms of wheezing and shortness of breath. What does this indicate about the patient's asthma control? A. Asthma is well controlled. B. Asthma symptoms are worsening and additional treatment may be necessary. C. The patient needs to increase the dosage of their corticosteroid inhaler. D. The patient should discontinue the albuterol inhaler. Answer: B. Asthma symptoms are worsening and additional treatment may be necessary. Explanation: using a short-acting base agonist like albuterol more than twice a week indicates that asthma is not well controlled and that the patient may require a change in their treatment plan. This typically suggests that the patient is experiencing more frequent symptoms and that additional controller medication such as an inhaled corticosteroid or beta agonist may be needed. Option A is incorrect because frequent albuterol use is a sign of poor control. Option C may be appropriate if the patient is using corticosteroids but doesn't address the need for more frequent intervention. Option D is incorrect as albuterol is necessary for acute relief. Question 17. Oxygen therapy. Indications. A 72-year-old patient with chronic obstructive pulmonary disease (COPD) is admitted with an acute exacerbation. Their oxygen saturation is 88% on room air. What is the most appropriate action regarding oxygen therapy for this patient? A. Start oxygen therapy to maintain oxygen saturation between 94–98%. B. Administer oxygen to maintain oxygen saturation at 100%. C. Begin oxygen therapy to maintain oxygen saturation between 88–92%. D. No oxygen therapy is needed as their saturation is within normal limits. Answer: C. Begin oxygen therapy to maintain oxygen saturation between 88–92%. Explanation: for patients with COPD, oxygen therapy should be aimed at maintaining oxygen saturation between 88–92%. Higher oxygen levels may lead to carbon dioxide retention and worsen respiratory acidosis in these patients. Option A is incorrect because oxygen levels above 92% may be harmful in COPD patients. Option B is not suitable as it could lead to hypercapnia. Option D is incorrect because this patient's oxygen saturation is below the normal range 94% or higher. Question 18. Pulmonary hypertension. Clinical presentation: a 58-year-old woman presents with dyspnea, fatigue, and dizziness on exertion. Physical examination reveals a loud P heart sound and mild peripheral edema. An echocardiogram shows an estimated right ventricular systolic pressure of 45 mmHg. What is the most likely diagnosis? A. Chronic obstructive pulmonary disease, COPD. B. Pulmonary embolism. C. Pulmonary hypertension. D. Heart failure with preserved ejection fraction, HSBEF. Answer: C. Pulmonary hypertension. Explanation: pulmonary hypertension is characterized by increased pressure in the pulmonary arteries, leading to symptoms such as dyspnea, fatigue, and dizziness, as well as signs like a loud P sound on examination and peripheral edema. An estimated right ventricular systolic pressure of 45 mmHg is indicative of pulmonary hypertension. Option A may present similarly but would have different findings on imaging. Option B would present acutely with chest pain or signs of a clot. Option D refers to a condition with preserved ejection fraction, but pulmonary hypertension is the most likely cause based on the echocardiogram findings. Question 19. ARDS. Risk factors and diagnosis. A 45-year-old patient is admitted to the ICU with severe acute respiratory distress syndrome ARDS following a motor vehicle accident. Which of the following is the most important risk factor for ARDS in this patient? A. Hypotension and shock during the accident. B. History of asthma. C. Recent upper respiratory infection. D. Trauma to the chest with rib fractures. Answer: A. Hypotension and shock during the accident. Explanation: hypotension and shock following trauma, particularly with significant injury and systemic inflammation, increase the risk of developing ARDS. ARDS is often triggered by direct or indirect lung injury, such as shock, trauma, pneumonia, or aspiration. Option B and Option C are less relevant risk factors for ARDS in the context of trauma. Option D could contribute to lung injury but is not as directly linked to ARDS as shock and hypotension. Question 20. Bronchoscopy. Indications and procedure. A 65-year-old patient with a history of smoking presents with persistent cough, hemoptysis, and weight loss. The chest X-ray shows a suspicious mass in the upper lobe of the right lung. What is the most appropriate next step in evaluating this patient? A. Start empiric antibiotics and monitor for improvement. B. Perform a bronchoscopy with biopsy. C. Obtain a high-resolution CT scan of the chest. D. Schedule the patient for a thoracotomy. Answer: B. Perform a bronchoscopy with biopsy. Explanation: in patients with a suspicious lung mass, bronchoscopy with biopsy is the most appropriate next step to obtain a tissue sample for diagnosis. This helps in confirming the presence of malignancy and determining the nature of the mass. Option A is inappropriate as this patient's symptoms are concerning for malignancy and antibiotics would not address the underlying issue. Option C is important for further imaging but would typically follow the bronchoscopy if malignancy is suspected. Option D is more invasive and not necessary at this point. Question 21. Pneumonia. Diagnostic approach. A 60-year-old patient with a history of hypertension and type 2 diabetes presents with fever, chills, cough, and shortness of breath. On examination, there are crackles in the right lower lung field. A chest X-ray shows a consolidation in the right lower lobe. What is the most appropriate next step in the management of this patient? A. Prescribe oral antibiotics for community-acquired pneumonia. B. Order Count to further evaluate the consolidation. C. Initiate broad-spectrum antibiotics and admit to the hospital. D. Perform a bronchoscopy to obtain a sample for culture. Answer. C. Initiate broad-spectrum antibiotics and admit to the hospital. Explanation. This patient presents with signs and symptoms of community-acquired pneumonia (CAP), and the consolidation seen on the chest X-ray supports this diagnosis. Given the patient's underlying comorbidities, hypertension and diabetes, they are at higher risk for complications, so hospitalization with broad-spectrum antibiotics is the most appropriate course of action. Option A is incorrect because the patient requires hospitalization for further management due to their risk factors. Option B is not necessary unless the patient does not respond to initial therapy or if an unusual organism is suspected. Option D may be considered in more severe or complicated cases, but is not first line for typical CAP. Question 22. COP. Medication management. A 68-year-old patient with chronic obstructive pulmonary disease (COPD) presents with worsening dyspnea and increased cough with mucus production. They have been using a short-acting BACE agonist, SABA inhaler for relief. What is the next best step in management for this patient? A. Continue using only the SABA inhaler. B. A long-acting BACE agonist LABA inhaler. C. Start oral corticosteroids for acute exacerbation. D. Discontinue the SABA inhaler and initiate oxygen therapy. Answer. B. Add a long-acting beta agonist LABA inhaler. Explanation. For patients with COPD, adding a long-acting bronchodilator such as a LABA to their treatment regimen is typically indicated to provide long-term control of symptoms. The patient's worsening symptoms suggest that their current short-acting beta agonist SABA therapy is insufficient. Option A is incorrect because the patient's symptoms indicate the need for additional treatment. Option C may be appropriate if the patient is having an acute exacerbation but should be done in conjunction with other management. Option D is not indicated unless the patient's oxygen saturation is low. Question 23. Pulmonary embolism. Risk assessment. A 45-year-old patient presents with sudden onset of shortness of breath, pleuritic chest pain, and tachypnea. They have a history of recent leg surgery and have been immobile for several days. What is the most appropriate diagnostic test to rule out pulmonary embolism (P) in this patient? A. Chest X-ray. B. High sensitivity D-dimer test. C. Computed tomography pulmonary angiography (EPA). D. Arterial blood gas analysis. Answer. C. Computed tomography pulmonary angiography (EPA). Explanation. EPA is the gold standard for diagnosing pulmonary embolism (P) as it allows for direct visualization of the pulmonary arteries and detection of emboli. This patient's risk factors, recent surgery and immobility, increase the likelihood of P. Option A is not specific for P and is less helpful in this scenario. Option B may be used as screening tool but is not definitive and is often followed by E-to-PA if the D-dimer is elevated. Option D is useful for assessing oxygenation and acid-base status but is not diagnostic for P. Question 24. Asthma. Inhaler technique. A 10-year-old patient with asthma is prescribed an inhaled corticosteroid inhaler. The patient's mother reports that the child is using the inhaler but is not achieving good symptom control. What is the most likely reason for this lack of control? A. The child is using the inhaler too frequently. B. The child is not using the correct inhaler technique. C. The inhaler dosage is too high for the child's age. D. The child is using the inhaler with spacer. Answer. B. The child is not using the correct inhaler technique. Explanation. Improper inhaler technique is a common cause of poor asthma control despite the use of inhaled medications. Common mistakes include not coordinating inhalation with activation of the inhaler or not holding the breath long enough after inhalation. Option A is incorrect, as overuse would be more likely to cause side effects, not poor control. Option C is unlikely unless the prescribed dose is specifically too high, but this is generally uncommon in pediatric asthma. Option D is a helpful tool and is often recommended for children to improve drug delivery to the lungs. Question 25. Interstitial lung disease (ILD). Diagnostic workup. A 55-year-old patient presents with progressive shortness of breath and a dry cough. A high-resolution CT scan reveals bilateral reticular opacities. The patient has a history of working with asbestos. What is the most appropriate next step in evaluating this patient for interstitial lung disease (ILD? A. Start empirical treatment with corticosteroids. B. Order pulmonary function tests. C. Refer the patient for A lung transplant evaluation. D. Perform a bronchoscopy with lavage. Answer B. Order pulmonary function tests. Explanation. Pulmonary function tests (PFTs) are a key part of the diagnostic workup for ILD. They can help assess the degree of lung dysfunction, especially restrictive patterns commonly seen in ILD. This helps to further characterize the disease process and plan management. Option A is premature, as corticosteroids are not the first-line treatment for all types of ILD, and a proper diagnosis should be established first. Option C is not necessary at this stage and would typically be reserved for advanced disease. Option D is not the first-line diagnostic tool for ILD, as it's typically used for obtaining sample in cases of suspected infection or malignancy. Question 26. Acute respiratory distress syndrome ARDS management. A 35-year-old patient with a history of sepsis develops acute respiratory distress syndrome ARDS after being intubated for respiratory failure. The patient's arterial blood gases show PAL-FeO ratio of 150. What is the most appropriate management for this patient? A. Increase the tidal volume to improve ventilation. B. Begin high-frequency oscillatory ventilation. C. Implement lung protective ventilation with low tidal volumes. D. Administer corticosteroids to reduce inflammation. Answer C. Implement lung protective ventilation with lower tidal volumes. Explanation. The key management of ARDS involves lung protective ventilation strategies, which include using lower tidal volumes, typically CAG of ideal body weight, to prevent ventilator-induced lung injury. A PAL-FeO ratio of 150 indicates moderate ARDS, and the key to managing this condition is minimizing ventilator-induced lung injury while improving oxygenation. Increasing tidal volumes, option A, would increase the risk of barotrauma and volatrauma. High-frequency oscillatory ventilation, option B, is typically used in refractory ARDS, not as a first-line therapy, while corticosteroids, option D, may be used in certain cases of ARDS. They are not part of the initial management for most patients. Lung protective ventilation with low tidal volumes has been shown to reduce mortality and improve outcomes in ARDS patients, making option C the most appropriate choice. Question 27. Oxygen toxicity and complications. A patient with chronic obstructive pulmonary disease (COPD) has been receiving 40% oxygen via a venturi mask for 48 hours. The patient is becoming increasingly confused, and blood gas results show a CO of 55 mHg and MAPO of 88 mHg. Which of the following is the most likely cause of the patient's condition? A. Oxygen-induced hypercapnia. B. Oxygen toxicity causing alveolar damage. C. Hypoxic respiratory drive suppression. D. Reversal of hypoxic pulmonary vasoconstriction. Answer A. Oxygen-induced hypercapnia. Explanation. In patients with COPD, long-term oxygen therapy at high concentrations can lead to oxygen-induced hypercapnia. This occurs because the body becomes dependent on the hypoxic drive to stimulate respiration. High oxygen levels can suppress this drive, leading to co-retention. The PCO of 55 mHg in this patient supports the diagnosis of hypercapnia. Oxygen toxicity, option B, is more likely to cause alveolar damage and inflammation, but is not typically the primary concern in COPD patients receiving moderate oxygen therapy. Hypoxic drive suppression, option C, is a consequence of oxygen therapy in COPD, but is addressed by using lower oxygen concentrations to maintain adequate oxygenation. Reversal of hypoxic pulmonary vasoconstriction, option D, is not relevant to the patient's clinical picture. Question 28. Pediatric ventilation settings. A 4-year-old child with asthma is admitted to the ICU for severe exacerbation requiring mechanical ventilation. The child weighs 15 kilograms, and the arterial blood gases indicate respiratory acidosis with ECO of 55 mHg and OH of 7.30. Which of the following ventilator settings is most appropriate for this patient? A. Assist control mode with a tidal volume of 8 mHg and PEEP of 10 centimeters Hg. B. Pressure support ventilation with a tidal volume of CAG and PEEP of 5 centimeters Hg. C. SIMV mode with a tidal volume of 5 AG and PEEP of 10 centimeters Hg. D. Volume control mode with a tidal volume of 10 AG and PEEP of 5 centimeters Hg. Answer C. SIMV mode with a tidal volume of 5 AG and PEEP of 10 centimeters Hg. Explanation. In pediatric asthma, mechanical ventilation should focus on minimizing the risk of barotrauma while ensuring adequate ventilation. The tidal volume is typically set at 5 CAG of ideal body weight. In children, SIMV mode is appropriate as it allows for spontaneous breathing with assistance, which is beneficial in a patient with asthma. To help reduce respiratory muscle fatigue, PEEP of 10 centimeters high is often used in patients with asthma to prevent airway collapse and improve oxygenation. Using higher tidal volumes options, O&D could result in ventilator-induced lung injury. Pressure support ventilation, option B, is typically not used for patients requiring high levels of assistance due to their severe condition. Question 29. Inhalation therapy and bronchodilator use. A 58-year-old male with chronic asthma is admitted for a severe exacerbation. The patient is receiving nebulized albuterol every 2 hours and his symptoms include wheezing, shortness of breath, and increased work of breathing. His heart rate has increased to 130 bpm and his blood pressure is 159 mmHg. What is the most appropriate act? Address the side effects of the medication. A. Increase the frequency of albuterol nebulization to improve bronchodilation. B. Administer an anticholinergic agent like ipratropium to reduce the heart rate. C. Discontinue albuterol and switch to a corticosteroid inhaler. D. Reduce the albuterol dose and consider adding a magnesium sulfate infusion. Answer: D. Reduce the albuterol dose and consider adding a magnesium sulfate infusion. Explanation: albuterol, a beta agonist, can cause tachycardia and hypertension due to its sympathetic stimulation effects. The patient's increased heart rate and blood pressure are likely side effects of the albuterol. In this case, the best approach is to reduce the albuterol dose, as overuse can lead to significant systemic effects. Adding magnesium sulfate, option D, can help relax bronchial smooth muscles and improve ventilation during severe asthma exacerbations. Increasing the frequency of albuterol, option A, could worsen the side effects and lead to arrhythmias. An anticholinergic agent like ipratropium, option B, could be added, but it is not the first line for addressing the tachycardia seen in this case. Corticosteroids, option C, are helpful in asthma exacerbations but would not directly address the tachycardia caused by albuterol. Question 30. Pulmonary function testing. Spirometry interpretation. A 50-year-old male presents with shortness of breath and cough is pulmonary function test PFT. Results are as follows. FEV equals 60% equals 50% predicted, and equals 80% predicted. What is the most likely diagnosis based on these results? A. Restrictive lung disease. B. Obstructive lung disease. C. Normal pulmonary function. D. Mixed restrictive and obstructive lung disease. Answer: B. Obstructive lung disease. Explanation: the FEV ratio is crucial in differentiating obstructive from restrictive lung diseases. The ratio of 60% is significantly below the normal value of around 75–80%, which indicates obstructive lung disease. In obstructive diseases like chronic obstructive pulmonary disease, COPD, or asthma, there is a reduction in the ability to exhale air, quickly leading to a deep FEV ratio. The FEV is also reduced 50% of predicted, which is another hallmark of obstructive disease. In restrictive lung diseases, the FEV ratio is typically normal or increased, but both FEV and FVC are reduced. Therefore, option B is correct, while the other options do not match the characteristic findings of this patient's PFT results.